Question, who do we screen for colorectal cancer? So, number one is age of 50 years old or greater. And the reason why this was chosen to be 50, this is not an arbitrary number. 90% of patients who were diagnosed to have colorectal cancer were aged 50 and above. But it does not mean that you won't have colon cancer before 50, because there's still that 10%, okay? And looking at this graph, so this graph shows every 5 years of the age group, and where the arrow is 50 to 55. So that's when you start a sudden increase in the risk for colorectal cancer. Another risk factor is family history of colorectal cancer. So how do we define family history? It has to be first-degree relatives. What are first-degree relatives? So it is parents, siblings, and children. The risk is much higher if the relatives were actually diagnosed before the age of 60. That means there is really a genetic component. Okay? And this graph shows you the younger the relative is at the time of the diagnosis, the higher the risk. It actually increases. If you don't have colorectal cancer family history, your risk is like 1, which is a basic baseline. If you have a family history, it actually goes up to 2. So if your lifetime risk is like 5%, it doubles to 10% if you have family history. And then if the family member is less than 45, it goes up to 4 times. And the more relatives you have, the higher is your risk. This slide is also very important. Only 1/4 of patients will actually have a family history. So patients without a family history, these are what we call sporadic colon cancer. So not just because you don't have a family history, you don't need to be screened. So the age and family history, those are what we call non-modifiable risk factors, because you cannot change your age, you cannot change your family history. If you had prior polyp in your colon or you had prior colon cancer, you had a higher risk because you already have, remember, the mutations in your system, so you had a higher risk to develop another cancer in the future. And there are also conditions like inflammatory bowel disease, in which your colon is very inflamed over a period of years. They are also at a higher risk, but luckily for us, this disease is actually not as common here in the Philippines. So now we go to modifiable risk factors. So people who smoke, they are at a higher risk to develop cancer. People who drink a lot of alcohol, and I think it's defined as 2 drinks per day. People who have bad dietary habits, they eat a lot of processed food. People who are obese and inactive. This actually will be discussed in detail by one of our speakers later on. So if you keep yourself fit and lean, you exercise, you're not sedentary, then you actually lower your risk for colorectal cancer, like Pia Wurzbach, Alice Dixon, and all these century tuna bodies. So now, how do we screen? So we know why we screen, we know who we screen. So this is the last question we need to answer. How do we screen for colorectal cancer? So this is a list of all the professional societies we have in the US, in Asia Pacific, in the Philippines, and basically all of them agree on the following: that we need to start screening at the age of 50. This we call average risk. So if age is your only risk factor, you are considered average risk. However, if you have additional risk factors like family history, inflammatory bowel disease, you need to be screened earlier, usually at the age of 40 or 10 years before the age of the relative. So example, if your father got diagnosed with colon cancer at 55, so you would be screened either 55 minus 10 at 45 or 40, whichever comes earlier. So 40, okay? And just last year, the Multi-Society Task Force on Colorectal Cancer, which is an association of 3 professional GI groups, have already classified all the screening methods we have for colorectal cancer, and they chose these 2 as the first tier for screening methods. So that's why I will be discussing this, since this is available in our country, these are available in the medical city. First one is colonoscopy every 10 years. The other one is doing a stool test, which we actually have a booth outside. The fecal immunochemical test, or FIT for short, but it has to be done every year. So these two are the cornerstones for screening for colorectal cancer. Okay, so what is FIT? Okay, so what you do here is you collect a stool specimen, okay, you submit it to the lab. Okay, what the lab does is they look for microscopic blood. Okay, so when we say screening, you don't have any symptoms, right? So if you actually are having rectal bleeding, you should not be submitting the stool specimens because it's obvious there is blood. What we're looking for is microscopic blood in a person without any symptoms. So the sample gets processed in the lab, they have some chemical reagent, and it looks for blood. The advancement of this type of test compared to the old guaya, which I think some of you may have done in the past, is a number of things. Number one, this is only specific for bleeding in the colon. Okay, unlike before, when we were using guaya, if you are having an ulcer bleed, you have an ulcer in your stomach and that bleeds, that will be positive for the previous guaya, but it will be negative on FIT. Okay, so the FIT is specific for colon bleeding. Number two, there's no more dietary restrictions. Because before, remember, when we have to tell our patients, if you're the patient, you usually get instructed not to eat certain types of food over 3 days because that will interfere with the test. But with FIT, there's no more dietary restriction. Okay, what are the disadvantages of FIT? Okay, number one, bleeding is transient. Remember, you're trying to detect bleeding from colon cancer here. But colon cancer does not bleed 24/7, right? So if you collect your stool at the time when the cancer is not bleeding, it will be a negative test. So another disadvantage is it needs to be done every year, okay? So if you do it this year, if it's negative, then you do it next year. However, if it's positive though, you need the next test, okay? There's no point in sending another stool next year because we already know you're positive for blood. Okay. The other test is colonoscopy. So what is colonoscopy? So colonoscopy is the use of a flexible instrument. It actually has a light source and a camera that is connected to a monitor. And the patient is actually sedated most of the time. Although we have patients before, they prefer to be awake during the procedure. And sometimes, some people who actually have a low threshold for pain, it may be uncomfortable for them. And that's why we recommend sedation or giving medicines to make the patient sleepy. Okay? Compared to FIT, okay, so this is a diagram of a colonoscopy. So this is a colon, and you have this flexible scope, okay? And then you could see a polyp here, you could see cancer. So in that way, it is a more accurate exam looking for cancer and polyps. It is also, the advantage is we could actually remove a polyp during colonoscopy. So it's actually one setting. You come in for your procedure, and then we do a colonoscopy, we find a polyp, we take them out, and then we already prevent progression of that polyp to cancer in the future. Okay. What are the disadvantages of colonoscopy? Because obviously, all tests will have advantages and disadvantages. Number one, a colonoscopy requires a skilled endoscopy. So you need a doctor to perform the test. So it's not like the FIT, you just collect your stool and submit it to the lab. Number two, obviously it is more expensive compared to the FIT. Okay. Number three, it requires extensive patient preparation. So just to give you an idea, to undergo a colonoscopy, you have to drink laxatives to clean you out, because there's no point in doing a colonoscopy on an unprepped patient and all we see is just stool, right? We won't see polyps, we won't see cancer. And if you actually have a heart or lung problem, you will be at high risk for complications from sedation, from the medicines that they give you to make you feel sleepy. So you will need to see your cardiologist and pulmonologist to be to undergo colonoscopy. So it's a little bit complicated compared to the stool card. And there are also risks and complications for colonoscopy, but under expert hands, it's actually very low. Okay, so this is just to emphasize that colon cancer is preventable. It is treatable, especially if we diagnose it at an earlier stage, and we could beat colorectal cancer too. So after talking about why, how, and who we screen for colorectal cancer, I know it's not readable, but these are a set of patients who have excuses not to have colorectal cancer. So this lady here, she's saying, I don't have any symptoms of colorectal cancer. So what will you tell her? Screen or no screen? Screen or no screen? Screen, right? Okay. How about this gentleman? He says, I don't have any family history of colorectal cancer. I don't think I need to be screened. Screen or no screen? Screen. Okay. How about this gentleman here? He says, I'm relatively young. I'm only 53 years old. I don't need to be screened. Screen or no screen? Why? 50 years old. Good. And then this other lady is saying, you know what? I cannot stand a colonoscopy. It is a very invasive test. Do you tell her screen or no screen? Screen, because there is the fit, right? So whether a patient will undergo a colonoscopy or the fit, the best test is the one that gets done. Okay, so we don't have to force the patient to do one specific test. So we need to talk to the patient and choose which test. So what are our take-home messages? Number one, why we screen, okay? So colorectal cancer is very common. It can be prevented if we diagnose it early. Who we screen? Patients who are 50 years old and above, and those with family history and other risk factors. How we screen? Remember the two tests? Just colonoscopy and FIT are the first tier screening tests. So what I want everybody in this room is, knowing what we know now, we should try to promote our advocacy of screening for colorectal cancer. Now you know the why, the who, and the how we screen. I want you to be a hero because you could actually save lives by promoting this advocacy. So go out there and be a hero like an Avenger. Thank you very much.